You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 5th, 2023. This is Kentucky Oaks Day. Tomorrow is the Kentucky Derby, the biggest day in Louisville, Kentucky. This week, I'm talking beta blockers, the public perception of statin drugs, trust in the medical profession, BMI, and TAVI. But a quick note on listener feedback. Regarding the observational study on lead extraction in patients with devices and endocarditis that I heavily criticized last week, one colleague asked me, John, why do journals publish so many flawed studies? Now recall that this was a hopelessly confounded non-random comparison wherein sicker patients surely got lead extraction, which then led to a strong association with lead extraction and better survival. I think my answer to the question is economics, and that is incentives. Incentives, right? Journals get attention, authors get publications, which help them advance in the field. Industry can sometimes win from these studies. In this case, the Flawed analysis promotes lead extraction, and the company that makes extraction tools stand to profit. Of course, legacy media also wins because they can cover these studies that garner attention. Rare is the presence of a news article saying that the study they covered is too flawed to draw any conclusions. Well, this is the core reason for the TWIC podcast, right? Incentives will continue to drive the publication of flawed studies. Consumers of the medical literature, like you and me, need to keep up our skills of critical appraisal. If there were only great studies and cautious conclusions, there'd be no need for this podcast. You could just read the study's conclusions and the editorials and guidelines. Now, another comment I received regarded my lengthy dive into the trial emulation paper in JAMA. Another colleague said, John, I don't know if it was me nodding off, but I just could not follow your discussion. It was too complicated. And I worried about that because this is literally the most important story of the year. Now, my 3-sentence summary is that some of the top data scientists in the world set out to emulate already published randomized controlled trials, and they tried to emulate them from observational data sets. Now, success at such an endeavor could change everything about medical evidence because observational data is so much easier to come by than RCTs. Their results were mixed. Sometimes they could emulate an RCT result, but sometimes they could not. So perhaps take another listen to last week. I'll talk more about this project. For now, I think RCTs remain the only standard for knowing what really works and really doesn't work in medicine. All right, let's talk beta blockers and new data. Now, whenever I give a talk on critical appraisal, I have a chapter on whether trials should have an expiration date. The classic example is ICDs for nonischemic cardiomyopathy. Herein, the trials that enrolled patients in the 1990s and early 2000s, like SCUD-HEF, found that ICDs reduced mortality when implanted in patients with heart failure. But then, over time, background therapy improved. The rates of sudden cardiac death fell, and a decade later, the Danish trial showed that ICDs versus standard medical therapy in patients with non-ischemic cardiomyopathy had no effect on mortality. My friends, it's the same therapy, the ICD, but it's just a different time. So quality measures in therapeutic fashion hold that we should use beta blockers in patients after myocardial infarction. And technically speaking, this is an evidence-based practice, right? But the trials that found that beta blockers reduced outcomes in post-MI patients were done decades ago, even before the reperfusion era. Now I'm talking beta blockers in post-MI patients with normal LV function. So the condition of being post-MI is clearly different now than it was 20 years ago. So the question is whether the drugs would have the same benefit. A journalist, Sue Hughes, covered a Swedish observational study which was published in Journal Heart, which drew from a nationwide database. The sample size of these post-MI patients between the years of 2005 and 2016 was greater than 46,000, and they excluded patients with left ventricular dysfunction and heart failure. And patients were allocated into two groups according to beta blocker treatment. The primary outcome was a composite of all-cause mortality, MI, revascularization, and hospitalization for heart failure. That's a typical composite endpoint. Overall, about 78% of the patients received beta blocker and 21% did not at the index date of 1 year following the MI. So there you have two groups, non-randomized, but two groups. Now, as I've said many times on this podcast, these are non-randomized comparisons. A doctor, not randomization, chose to use beta blockers or not use beta blockers. So then the authors have to do statistical adjustments to attempt to match the two groups. And after these adjustments, they found absolutely no difference in the primary composite outcome. The hazard ratio was 0.99 with very tight confidence intervals of 0.93 to 1.04. So the authors concluded, quote, evidence from the nationwide cohort study suggests that beta blocker treatment beyond 1 year of MI for patients without heart failure or LV dysfunction was not associated with improved cardiovascular outcomes. Okay, my comments. This was a particularly strong association study, right? Large numbers, a robust national database. It seemed to be pretty good statistical adjustments. And the lack of association of beta blocker versus no beta blocker in post-MI patients does comport with what you would expect in an era where MIs are completely stopped by reperfusion therapy. In other words, the finding of this non-randomized comparison is pretty plausible. You'd expect it. Yet I think we have to be careful not to make causal conclusions. Whenever clinicians decide on a treatment, rather than randomization, there can be confounding variables. Now, the good news is that the authors tell us that there are going to be five randomized controlled trials that will test beta blockers in the post-MI state. One's called Beta AMI from Norway. There's Reduced Sweetheart from Sweden, DanBlock from Denmark, another RCT from Spain, and a trial called Abyss from France. I mean, in a few years, the use of beta blockers in patients after MI who do not have LV dysfunction will be one of the most studied interventions in all of cardiology. Now, I lead with this topic because trial settings are such a hugely relevant thing to translating trial evidence. The post-MI setting has changed so much. I will bet any listener a big cappuccino that these studies will be neutral, and that's going to be because event rates after an MI is reperfused. After you prevent the damage from an acute occlusion of a coronary artery, it will be hard to lower event rates much with a beta blocker. So I say kudos to all the investigators who are going to study this topic. Clearly, post-MI beta blocker use will be one of the most studied areas in all of cardiology in the coming years. The next topic is the public perception of statins, and I'm going to get a little bit into trust in the medical profession, and we'll even talk about BMI as a measure of obesity. So a Stanford research group publishing in JAMA Network Open, they reported a qualitative study of 10,000 statin-related discussions on the internet forum Reddit over the last decade. They actually used a pretty complicated AI program, one that I don't exactly understand, to cluster these discussions into sort of thematic groups. They seemed surprised by their findings, but I wasn't. Their first observation was that the raw number of discussions about statins have increased over the years. Another observation was that the AI program was able to identify certain thematic groups, like, say, for instance, ketogenic diets and diabetes and supplements, and other statin side effects, and then statin hesitancy. They actually had a topic on clinical trial appraisal and pharmaceutical industry bias, and even red yeast rice and statins. The authors were able to do something called a sentiment analysis, and they noted that most discussions had either a neutral or negative sentiment. Now, in a news article, senior author Fatima Rodriguez made some interesting comments to journalist Sue Hughes. Let me just read a few of them to you. Quote, "Some of the themes were surprising to us," she said. "While we expected discussions on side effects, we were surprised to see so much discussion refuting the idea that increased levels of LDL were detrimental. There was also a large amount of posts on statin use being correlated to COVID outcomes, and our findings show how widespread this misinformation is." She then said, "As a preventive cardiologist, I spend a lot of my time trying to get patients to take statins, but patients often rely on social media for information, and this can contain a lot of misinformation. Finally, we need to understand all sorts of patient engagement and use the same tools to combat this misinformation. We have a responsibility to try and stop dangerous and false information from being propagated," she commented. All right, my comments. Now, obviously, this qualitative study with this novel machine learning methods is not an RCT that's going to change practice tomorrow, but it does shed light on an important topic, and that is trust in the medical profession. Statin drugs. Let's talk about statin drugs. I mean, these are the most rigorously studied medical intervention, bar none. More patients have been enrolled in statin trials than any other drug. Most statins are generic, so there are very few people getting rich on statins anymore. Statin drugs have been incredibly consistent in delivering 20 to 25% reductions in future cardiac events. The meta-analyses of these trials show almost no heterogeneity. You can argue about the absolute risk reductions on an individual basis, but the relative risk reductions and consistency of the benefits of statins are crystal clear and backed up by very strong evidence. In terms of side effects and safety, statins, when studied with proper placebo controls and blinding, the statin drugs have minimal to no side effects. Yes, it is true, statin trials were done over 3 to 5 years, and as Dr. Rod Hayward from Michigan has well described, there are unknown unknowns of taking the drugs over 10, 20, and 30 years, but that could be said of almost any drugs that we take over that period of time. So here is my question. How can it be that such a universally helpful drug with minimal to no side effects and low cost carries so much negative baggage? I mean, think about that question before answering it. Here is my answer. My answer is, it is the fault of the medical profession. This paper from Stanford reveals the symptoms of distrust of us, of the medical profession. In my opinion, we are increasingly distrusted because of our approach. It is not the fault of social media platforms, nor those who use social media platforms to speculate about things. My theory is that instead of promoting a culture of critical appraisal, we, as in the medical profession, take a paternalistic, holier-than-thou approach to certain things. Think, for instance, guideline-directed medical therapy writ large on the American people. We saw it during the pandemic. Instead of being transparent about the vast uncertainty, we decreed and mandated things without evidence. We leaned on expert opinion when we should have used the uncertainty to promote a culture of randomized trials. It could have been a revolution in epistemology, right? We could have said, gosh, this is a once-in-a-lifetime pathogen, and here is how we're going to learn more about it. We're going to do different randomized clinical trials, different approaches to learn more. Now, unlike Professor Rodriguez, I do not try to convince patients to take a statin or any medical treatment. I see almost all medical treatment as preference sensitive, especially preventive medicine. The approach I take is to be an advisor. I mean, even as an electrophysiologist, many patients take the opportunity to ask me about their statin drugs. I am shocked at how few of them have been shown the risk calculator so as to understand the risk on and off the drug. I often ask patients what their doctor told them, and they respond, my doctor said I needed to take this to lower my cholesterol. Well, my friends, in that sentence, in the attitude of that sentence, is a grand metaphor for why we have lost trust. It's exactly why there are online discussions questioning basic things about medicine. because people know they will get the "you need to take this pill to lower your cholesterol" line from their doctor. It's the same with "you need this ICD or you will die," or "you need to take this anticoagulant or you will have a stroke," or "you need to take this colonoscopy or you will die of cancer." These are all probabilistic decisions that can be discussed at the level of whatever your patient is at. I don't think that happens enough. It doesn't happen in guideline documents, in quality measures, and in the public sphere. The American medical profession treats people as if they are stupid, and it makes me mad. Take diet. We know that eating pure sugar and processed food is terrible for you, but we don't know the first thing about the heart healthiest diet. We probably never will, and we should just say that. People would trust us more if we acted like humble advisors rather than pompous professors. And finally, one more trust shredder. People read about our debates over BMI as a measure of obesity. A normal person thinks, how can they argue about something so tangential to one of the nation's top health problems? Normal people know the problem isn't how we measure obesity, it's how we fix it. So I say good on the Stanford team for publishing these observations. We need more of these kinds of qualitative studies, so someday the medical profession will better understand how the public sees us. Combating misinformation begins in our clinics and medical schools. Now let's talk about access to TAVI. The Canadian Journal of Cardiology has published a study looking at access to transcatheter aortic valve implantation, or TAVI. Now, I ride a Pinarello, so I favor TAVI over TAVR. But if you're American, it's transcatheter aortic valve replacement. This topic, this access topic, is a hot potato. Here's why. When done in high or moderate risk surgical patients, TAVI can be a huge net positive for patients. You know how I feel about low surgical risk patients. We need more long-term data, but clearly older patients with aortic stenosis who have good insurance and reside next to big centers in big American cities have a greater chance of getting TAVI and getting benefits from that procedure. So access to TAVI is a good thing, right? Yes, but there is a downside. There are always downsides. Here's the downside of increasing access. TAVI takes a long time to master. High-volume operators and high-volume centers will perform better than low-volume centers and low-volume operators. So the downside or risk of expanding TAVI access to, say, more rural areas is that some of this access is going to be to low-volume centers. So this study was an observational retrospective cohort study from Ontario and New York State, and the goal of the authors was to explore the variations in access to TAVI in the two geographic areas. Now, one area had higher access, of course, New York, and the other area had lower access, Ontario. The populations are pretty close, 15 versus 19 million, and obviously Canada has a much different system, a universal public health system versus New York State's mostly fee-for-service and mixed insurance model of healthcare. The primary outcome was post-TAVI 30-day in-hospital mortality and all-cause readmissions. Now, to get to this outcome, they had to use observed versus expected outcomes for New York patients had they been treated in Ontario. That's, of course, a red flag. So they had 17,000 patients had TAVI in 36 hospitals in New York versus 5,000 patients had TAVI in only 11 hospitals in Ontario. In Ontario, access to TAVI increased to 87 TAVIs per million in 2018. In New York, access to TAVI increased to 220 per million, so much more. They're almost threefold higher use of TAVI in New York State compared with Ontario over this time span. And the 30-day mortality was 3.1% in Ontario versus 2.5% in New York. And when they adjusted this, it's translated to an observed to expected ratio of 0.70. And that was statistically significant. So a 30% better outcomes in New York. Now, interesting was that when this indirect standardization was done for readmissions, they found no difference. And why is that? And that's a clue, perhaps. So the authors concluded, quote, Having greater access to TAVI may be associated with improved outcomes, potentially because of intervention earlier in the trajectory of the disease. Okay, so my comments. Whenever I teach critical appraisal or my talks on critical appraisal, I start by asking the reader of a paper to consider what a study is for. Now, sometimes papers are for marketing, sometimes it's to answer a truly scientific question. When you read the author's discussion of this paper, when you read between the lines, I get the sense this was a call to improve access to TAVI in Canada. Here is a quote from the discussion. Quote, "It is an important area for further work to understand if the differences we observe among our cohorts are indeed due to fewer peri-procedural issues. If so, this may be due to the New York cohort being earlier in their disease progression by having greater access and therefore shorter waiter times," end quote. So the issue of access to TAVI, access that is from high-volume skilled operators, is a vital question. The problem is that this study has way too many limitations to answer the question. They had no information, for instance, on wait time or events in New York. Recall that they had to use an observed versus expected outcome. Further, like all non-random comparisons, they cannot exclude confounders, such as outcomes might have looked worse in Canada because they operated on sicker patients. And I worry a lot about confounding in this paper because readmissions were not different. And if this was a true association, in other words, New York is that much better, why would they also not have fewer readmissions? Look, I'm sure the authors are well-intentioned, but studies like this are ill-advised. The methods of this analysis are simply too limited to persuade anyone. Better access to TAVI is indeed a laudable goal in New York or Canada or anywhere. But using flawed analysis as a means to that goal is problematic because it reduces trust in the scientific method. I mean no malice to the authors or to the journal editors, and I speak as a consumer of medical evidence. But I wish that accomplished academics resisted the urge to do these sorts of analyses. I wish journal editors and reviewers refused to publish them, because for every flawed analysis, especially those that come with outsized conclusions, trust in medical science is diminished. Now, improving access to TAVI is not necessarily going to be a universal positive, right? If that access comes from low-volume centers. This is a really important area of study, but it's going to take a lot stronger methodology than those used in this paper. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And if you like this podcast, please consider taking the time to giving us a rating. Even a 1 or 2 sentence review goes a long way. Also, if you disagree with me, please let me know. I learn from comments. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.